Hello, everybody. Thank you for coming to this session at the end of the day on Monday on cancer innovation. I am Erika Smith. I'm a columnist at the Los Angeles Times. Very happy to be here, my first South by Southwest. I wanted to introduce our two panelists, and I'm going to ask them both to talk a little bit about their organizations and what they do. But to my immediate left is Harlan Levine. He is the president. Let's see, I'm gonna get my titles right here. President of Health Innovation and Policy at City of Hope. And to his left is Ysabel Duron, who is the founder and president of the Latino Cancer Institute. First, Harlan, both of you, but let's start with you, Harlan. Talk about you and your organization and what you do.
Great. Well, welcome everybody, and thank you for coming. I think people can hear well enough. So I am an internal medicine doctor by practice and training, and I've been in health management for several decades now, 2 decades. But I've been at City of Hope for 10 years, and City of Hope is a National Cancer Institute designated comprehensive cancer center, one of only a little bit more than 50 in the country. And we're focused on cancer treatment and research. We've been we started in Southern California about 110 years ago, and we were there for the first 100 years, and now we're branching out, and we have cancer facilities in 5 major counties in 4 states, so including Georgia, Illinois, and Arizona. And we'll talk more about City of Hope as we have time this hour.
Very good. Hello, everybody. Welcome. Thank you for being here. Can I ask an invasive question? And you can feel free not to answer. How many of you have been either impacted personally by cancer, or someone you know, someone you love, someone you work with? Whoa. This is the world, is it not? I am a cancer survivor. I'm actually a journalist by training. Spent 43 years in television news mostly in San Francisco Bay Area. But in the middle of that, I came up with a cancer diagnosis, and I looked around the room and I said, where are all the Latinos? And I recognized I was a person of privilege. I could speak the language, I had great insurance, and the doctor asked me if he wanted me to treat him like a celebrity. I said, well, I had decided I was going to turn the camera on myself to show people in the Bay Area what the big C looked like at the year 2000. And I said, no. I said, if you treat me like a celebrity and you give me special care, this is not what the majority of people get. So therefore, this will be an inauthentic report. But as a result of that put me out in the public space, and some people from Stanford came and said, we need you to talk to these Latinas about the work they're doing. So I did. They were a small group working with Spanish-speaking women with breast cancer. And I saw their work. I said, it's going to be needed. You have to expand it. You'll probably have to become a nonprofit. And they talked about it for a while. And then I walked out of the room and they elected me president. So thus began my work on the cancer space. And I spent 17 years doing and working on this is in the Santa Clara County in Silicon Valley, working with low-income Spanish-speaking immigrant and undocumented. And this is what I called my community of practice. This is where I began to see huge gaps for multiple reasons. And ultimately, after 17 years, I recognized I could help one patient at a time, but if we didn't deal with systems problems, we were never going to be able to help large groups of people, and not just Latinos, but many low-income, vulnerable, monolingual speaking people around the country. And so that has been why I went to the national level, both to amplify the Latino voice around these issues, to continue collaboration with research to find out what are the basic causes of cancer in the Latino community, and thirdly, to go into the sausage making, which is, policy, the thing that I like the least, but the thing that ultimately becomes one of the most important. And that's how I had the good fortune of starting to do some work with City of Hope.
Thank you. Yeah, we've talked a lot about community and a lot about, some of the barriers to treatment. And but first, Harlan, can you talk a little bit about why cancer treatment is a little bit different than other chronic diseases? I mean, we just talked about we're all been touched by cancer, most of us in this room, but go a little bit behind the scenes on that.
Yeah, I'd love to, and I really appreciate each of you showing up, because this is such an important area that's really underappreciated by the public, and we really want to get the word out. So cancer is different from other chronic diseases for many reasons. So first of all, we all know it's scary and it's life-threatening. But the other differences are that unlike any other area of medicine, the speed of change has made it very difficult for many of even the oncology specialists to keep up. So we have a situation in the world right now where the gap between optimal care that you and I would want to get and maybe celebrities get and the usual care is actually widening. And there aren't other conditions like that. And then the other piece that makes it so important is that I'm an internal medicine doctor. I take care of high blood pressure, diabetes, high cholesterol. To be perfectly frank, if it took me 6 to 12 months to get the exact right treatment, it wouldn't make a difference because you're really playing for the long haul. But with cancer, your best chance of diagnosis is your first chance, actually your best chance of cure is your first attempt at cure. So it's really important to get the right diagnosis, and what we're seeing is that so many people aren't getting the right diagnosis, the right staging, and then they're not getting access to the right first treatment. And we're losing lives because of that. And what we're trying to do here by coming to South by Southwest and talking to as many people as we can, we want people to really understand that this is both personal, but it's also a policy issue. And you're going to hear a little bit about that on the panel today.
Yeah, talk a little bit about, and we're going to define the problem first before we talk about the solutions. I know everybody wants to hear the solutions that are at work in California, but I do think it's important that we kind of get on the same page. So can both of you talk a little bit about the specific obstacles to cancer treatment? And I know you have come at this from different points of view, but I don't know who wants to go first.
Can I say first, and I think both Harlan and I agree that, we're dealing with a lot of innovation that moves faster than the sound of light. We're all seeing it encompass our lives, and half the time we don't see it and recognize it. So, and here we are talking about AI, which is really critical. I just think that we've got to get back to the basics first before we can really teach many patients how that integrates into their health, how they have to protect it and guide it. And too many times AI is so far ahead of them and them being aware that it is really critical for us to have large armies of people being able to interpret for their families, oftentimes, vulnerable populations. And so the more you can share this wealth of information with those who have the least amount of information and understanding, and particularly those who live in marginalized communities where there's also a language barrier, which is huge, the harder it is to help them make that leap from basic care to these really innovative opportunities that are also barriers because of policies, because of systems problems. And so we're here, which is what I love about City of Hope, in which we're trying to do this leap. We're trying to make sure we leave nobody behind. At the same time, we're making sure that innovation for innovation's sake is not harming people. And so, there are a ton of social determinants of health. Has everybody heard of social determinants of health? We know they intersect our lives every which way we can, but they have oftentimes particularly exacerbating impact on communities of color, low-income people. There are also the political determinants of health, and you can read that from Daniel Dawes, and those intersect with, those are how we came to the social dynamics of determinants of health, because they'll stick poor people in neighborhoods where trucks run through and there's a plant spewing, environmental toxins. And so as we start to really look at the world in which we live, we can see how those things have happened and how we can make differences in those policies when we step up, we talk to our legislators, and we help them see the differences that can be made and should be made. Because for all we know, it could be your own family that's facing those too.
And from the industry perspective, there's also some obstacles as well, correct?
There are, and I really want to start with the problem, and then we'll get to the obstacles, and hopefully we'll get to the solutions, because people want to hear the solutions. But
Absolutely.
This is not a trivial problem. African American women have a 4% lower incidence of breast cancer, but a 40% higher death rate from breast cancer. If you look at Latino patients, they are 15% more likely to get diagnosed in late-stage lung cancer than early-stage lung cancer, and 50% more likely then to not get any treatment at all. Asians are, 3/4 of Asians don't even screen for colon cancer. So there's a significant difference that's not one that you can just ascribe to one or two issues. These are multidisciplinary issues. So you heard about some of the social issues. One of the areas that I want to talk about is the way we augment or enhance some of these gaps through our own industry. And if you look at like one of the biggest things you hear in healthcare today is there's an affordability issue, which then leads to this term called value-based care. And we'll talk a little bit about value-based care in a moment about why that upsets me so much, the use of that term. I love value-based care in concept, but it's how we apply it. But one of the applications is that the health plans for years have been narrowing the networks. So when you pick an insurance plan, you have to pick a plan that may have a very small network or a limited network, or in California, you may just pick a medical group that you have to work with. Well, I'm a primary care doc, as I said. That works extremely well for preventive medicine, primary care, even for diabetes, where there's a lot of expertise out there. But with cancer, here's the problem. It's an inconvenient truth that cancer is actually becoming more specialized. Everyone loves precision medicine. That's the use of genomics to help you zero in on really treating the cancer patient more precisely. But that means every cancer now has its own DNA blueprint. And if you're a general oncologist seeing 20 to 30 patients a day, it's really impossible to keep up with all these cases, all the different types. Now, you could do a great job in a lot of cancers. You could do a great job in many ways supporting the patient and the family and the journey. But when it comes to really complex cancers, really specialized cancers, there's no way you can keep up. So now go back to the narrow network. You, as a beneficiary or a member of an insurance product, you now get a cancer diagnosis. You may end up with a group that does not have the expertise, and they've now set up barriers and hurdles that you have to climb through. In fact, they call it leakage if, God forbid, you get out of your medical group and you get to the specialists that you see. So as cancer becomes more sophisticated and we shift more people into these narrow network products, insurance products, you're going to see a bigger gap. And we know that minorities are disproportionately enrolled in these narrow network products. So while we are impacting everybody, we are continuing to disadvantage minorities more in terms of access to the specialized care. One last point. In cancer, 20 years ago, or 30 years ago when I was in training, going into a clinical research trial was like finding a needle in a haystack. That you try a new drug, it may or may not work. With precision medicine, where you get the diagnosis of an exact mutation that led to the cancer, you have a precise drug that fights against that mutation, your best chance of cure may actually be a clinical trial. Well, if you're in a medical group that doesn't have an academic partner associated with it, what are the chances that you're going to end up in a clinical trial? It's very few. Again, let's look at the stats. About 15% of cancer cases in this country are African American people. Only 4% of enrollees in clinical trials are African Americans. There's a gap, and we really need to think about, what we can do from a industry point of view and a policy point of view to make sure that gap's not widening and that we're really narrowing the gap. Otherwise, we're going to be perpetuating and really even increasing disparities in the future.
And quickly, before we get to California, you talked about clinical trials, and that's actually really interesting about the low percentage. What does that do for drug development on the other end if you only have a small percentage of, say, African Americans in that pool?
Yeah, it's a great point. You're basically perpetuating what has been going on for way too long, which is you're not really determining what's the best outcome for a Latino population or a black population. And again, you're just perpetuating the gap. You know, this was a problem. I remember when I was in training, and I promise not to digress too much, but you know, we got these great new blood pressure medicines that came out. 20 years later, people figured out they don't really work in African American populations. I mean, but it took 20 years because we didn't have enough data. So we need to disaggregate that data and really look at it by ethnic group, there'll be all sorts of groups, you know, it'll be mutational, but we just have to get better at it than we are today. And if we don't enroll, we're not going to solve the problem.
Erika, I have to pick up that point. There are 62 million Latinos in this country, and we're not a monolith. We are diaspora. So we can't all be treated by the same drug. Our genetics are different, our lifestyles are different, our geography is different, our environments are different. And when you're not disaggregating subpopulation data, which not only impacts Latinos, but it impacts Asian Americans, then you're getting even a poorer outcome for the drugs, whether they work or not. So for instance, a colleague of mine who is a pulmonary specialist said, why do Puerto Rican kids not respond to asthma drugs like Mexican kids do? And why is it, for instance, that Mexican kids have a couple of mutations? These are pediatric patients with the most common form of leukemia, ALL, who have a 40% higher mortality rate risk than non-Hispanic white kids. And until they started doing and diving into research and starting to compare and contrast, did they discover, and I don't know if you'd read of the Loma Linda study, which came out about 4 years ago, in which they finally started looking at why are these Latino kids not responding to the drugs with the same efficacy as these non-Hispanic white kids are, and they discovered what they called an addition and a deletion. My genomics. So I give you the general picture, but bottom line is they were missing something and there was an addition to something, and so they were responding very differently. And until we, as Latinos, get disaggregated data, doctors can't make a really fair judgment about what works and what doesn't work. Yeah. But that also works for different groups of people. Even in the white population, there are going to be differences. We only make up about 7% of clinical trials across the country. So there's a lot of work that needs to be done towards those solutions and then towards the usage of these very innovative drugs and therapies.
So let's talk about policy reform. I mean, so you've seen these problems, particularly with cancer. You did some work in California. Can you talk a little bit about how that came about and what it is?
Yeah, we're really excited about the work we did in California. So everyone's familiar with Medicaid, which is a state program for people that make below a certain amount of money, certain amount of income. That's 33% of California. So it's 33 million Americans, so it's like about 11 million people. And we saw in the data that if you were in Medicaid and had lung or breast cancer, your outcome was worse than if you had non-Medicaid insurance. Here's the even scarier data. There are other types of cancer that you were better off having no insurance at all. So we felt like the system was broken, so we took a look at it, and we realized that in California, you really got put into these small pods of practices with very little ability to access academic medical centers or the research trials. So a couple years ago, we started a coalition, including Ysabel's organization, that was focused on the fact that cancer care is different. That's what it was called, cancercareisdiff.org. You can take a look at it. And it was a coalition of saying we have to do something to solve the problem. So we started with the first state cancer patient Bill of Rights. And I won't go through the entire Bill of Rights, but it basically said you had the right to the right level of expertise. So it wasn't saying that everyone could go to an academic center, but everyone should get to the right level of expertise for their cancer. It should be culturally sensitive. It should have appropriate care navigation support. You should have access to not only the latest known treatment, but the opportunity for research as well. But the idea was that every patient, whether they're on Medicaid or not, but starting with Medicaid, should have just basic rights. In my profession, I've focused on population health. I've been at Anthem, I've been at United Healthcare. how you treat a whole population is one way, but when you have cancer, this is the worst, among the worst things that's going to happen to an individual in their life. It is a terrible, unwanted journey. The entire family is involved. You can't just use homogeneous solutions that work for primary care and preventive care. So we created this Bill of Rights, but it didn't have any teeth to it. And here's what you were asking about. What did we do in California? Well, the good news is there were some really passionate state legislators who said, City of Hope, we love what you've done with your coalition, and cancer care is different. Cancer care is diff. But you got to put some teeth in it. So we wrote a piece of legislation, and to make a very long story short, it got passed unanimously by both the State Assembly and the Senate, signed by our governor, and we now have the California Cancer Care Equity Act. Thank you.
Yeah, that's right.
Yeah, okay, thank you.
SB something.
Which basically says if you have a complex cancer and you are in Medicaid, you have the right to access specialty care, to get the right precision medicine test, the right opportunity to be in research, and the right level of expertise. And the good news is the groups that are now taking care of these patients have the affirmative right to discuss those options with those patients. So it's new, it's getting started, but we're really excited. We think it's a model for how other states can start to address these health disparities from a policy perspective.
Well, you know, Erika, what was interesting when I came into the group, I said, so who's going to tell them about it? Because this is part of the problem, the lack of awareness and education and access even to the information. And the one thing that he forgot out of the Bill of Rights that I think is absolutely critical, and that was understandable language. So that means speaking to people in their own language. I mean, we dealt with a patient when we were doing work on the ground where the doctor put him on the translator machine, he was Latino, put him on the translator machine to tell him that he had a terminal diagnosis. When he didn't respond to the translator machine, he called in my patient navigator and said to her, talk to him, so we need to tell him this. So now he's asking my patient navigator to tell the man he's going to die. So she just talked to him and discovered he didn't even speak Spanish. So she was speaking with the nephew or the cousin. Turned out he spoke Mixtec. So they managed between the numbers of them to tell this man of 54 years old that he had a terminal diagnosis. And the doctor knew, he got the message when the wife started crying. That is not the way to do health care. So you need that human touch, you need that language that they understand and connect with, and you need to be able to know that it's there when you need it. So one of the things when I walked in, first thing I said, how are we going to make sure that these patients are aware that this exists when life gets in their way, and there's so many things that come past their lives, and they don't know about it. So they need this navigation, and that's the third thing that we've done in California, and that Governor Newsom really signed into, and that was that they determined, and the president did so as well with his, is it the Cures Act, or there's so many he's written, but they actually support building a community workforce with community health workers or promotoras. That is huge. That is big because they're all over the country, and they're going to make that difference in navigating from community through systems and through cancer care. They will make that difference with that cultural understanding, that language understanding. And I was really thrilled when once again, a model, California, not only you can be reimbursed through, clinics can be reimbursed through Medicaid for utilization of these CHWs in your clinics, and then Governor Newsom put another $10 million in to help train and certify and help community-based organizations to get their CHWs working in coalition and in partnership with particularly public health systems that don't have necessarily cancer centers, but that's where most of these folk go. So there's a lot more need for collaboration and bridging, but this was a huge and big start.
Yeah, Ysabel, actually what you were saying about, talking about the patient who was told this in this very convoluted way. That hits home. My godson was diagnosed with cancer when he was 1, and it's a Honduran family, so I kind of was this weird go-between sitting in the room when the diagnosis happened. So that really hits home. But it also makes me think, too, with this bill in effect in California, what is the ideal patient experience now? Say, you're in that situation, say it's this family, what would be different under this law that exists now as opposed to what it would be? What would be perfect?
What's ideal was the model that I built.
Of course.
And it starts, go ahead.
Well, I do want to separate out, just for clarity. The bill focuses on getting to the right level of expertise.
Yes. Mm-hmm.
The Cancer Center Bill of Rights addresses what Ysabel is talking about.
Okay.
So that has to get more embraced. But I think the reason why it's important to make that statement is that people just aren't aware of stories like Ysabel just said, and they happen all the time. I have, similar stories, and they're all they're emotionally evoking. And we could tell these stories, and we'll end up weeping if you hear about how difficult this is for families. We need to do better. And I guess what I would say is, in general, in addition to the language and the culturally appropriate delivery, in cancer, we need to do a much better job of providing benefits for supportive care. It's the journey that,
Right.
if you think about, I would imagine, I don't want to be presumptuous, but many of us in this room have a lot of privileges and just knowledge and people we know. If you get diagnosed with a breast lump, by the time you get your first treatment, you might have had 30 different visits that you've had to coordinate. That's not an out of the ordinary number. Think about how hard that is if you don't speak the language. Think about how hard it is if you don't have full benefits for that. Think about how hard it is if you have 3 kids you need to help parent. So, this is really difficult, not to mention the stress of waiting for results and actually being told you have 3 options and being told in a language you kind of understand but not fully. And the decision's yours, by the way, because you got 3 options and they're all equally good, but they all have, it's just overwhelming. So we need to understand that cancer care, the things that MDs and nurses do is great, but you also have a need for navigation and emotional support. We've taken a step towards solving that with some codes that are now reimbursed by Medicare, but those are like tactics. We really need to understand that it's a whole ecosystem that needs to come together to support the patient in a culturally sensitive, language-sensitive way.
Well, I think that this is a particular model that can serve any community, because bottom line, where does it start? It starts with information in community, for them to know, to be exposed to these issues. One of the things I said when I started working in the cancer space was, talking about cancer won't kill us, the silence will. Because Latinos, there are many who culturally and socially and with their practice don't even want to hear the word cancer because they think that means death. So that's where you have to start, because they're not going to go to screenings. They don't want to know that they're going to die if they end up with a cancer diagnosis. So you start back here in community using community health workers. And once you educate them and identify those who need screening, you hand them over to the clinics, and the clinics pick it up from there. And then if they get a diagnosis, they get because you always have to use the community healthcare model, which is constantly navigating that person, because they're like familia, they're like family. You feel comfortable with them. You can talk to them. Your good is what they're concerned about. And so you can navigate them through the system if clinics, if public health care systems, and if comprehensive cancer centers will accept this model. Because that's why I'm saying this is the next step, the community health care model that the governor and even the president support, because it is getting systems that are very entrenched in how they see things work, including with certification, that it has to be at least a college graduate with a BS degree who's been certified up the wazoo. Sometimes it's just plain old human touch, right, is what people need, but helping them get through those systems. And so we developed that model. So we started with education, and we ended up with a patient navigator inside the cancer center in a public health care system. And we navigated 1,000 Spanish-speaking patients We went to 25 funerals because it doesn't stop at the door of the hospital. And when I asked one of the patients who was dying, she was 4-stage colorectal cancer, and I said, out of all of the things Claudia has done for you, which is the most important? She said, she spoke my language. Communication is everything. And what is that? That's about the heart. And we all feel that difference when someone there cares about us and is embracing us and is helping us. And that's where the language barrier becomes one of the biggest problems, I think, in any care, in any system. And I think if we can get, part of my issue is changing systems, thinking about how important community health care and community-based organizations are central. We saw it happen. Excuse me, but did we not know it happened during COVID? Some of the most important people who stepped up to the plate and helped get communities who were frightened, vaccinated, and tested were community health workers, whom public health care systems employed. And then what happened? They kind of let them go out. They should become part of pandemic planning, and they can become part of cancer systems.
You were going to add something.
Well, yeah, I think Ysabel's points are so important. And you can only accomplish this through partnership. It has to be a collaboration. Let me just give 2 quick examples. So one is, there's a convergence between what Ysabel is talking about and what a City of Hope institution would be thinking about. 15 years ago, City of Hope was basically a cancer hospital where you'd have to go there to get the care. And it was so busy, you'd have to kind of almost get admitted to get there. But we then started to spread out, one at a time until we got 40 different community practice sites. So we're bringing our expertise into the practice to take care of patients, because cancer care is largely outpatient. We're able to deliver high level. And now we're taking it to another step where, again, in partnership with the community, to your point, we've invested with actually support from the federal government, a grant from an earmark, from a grant, and from donors. We've built this first comprehensive cancer prevention and screening mobile van. It's like a truck where you can go in and just like you said, it's not just come in and get your mammogram. It's come in and sit and talk to someone in the community about what you need and why this is important. And then if we detect something, navigating them, not to City of Hope, but if they want to come to City of Hope, that's great. But, is there a local resource that we can help connect them to follow up? And the reason why I think that's important is that it has to be a culture change. In some cultures, prevention and screening, as you heard, it's not the norm. And if you don't bring it into the community and make it the norm, you're not going to get the change. And you've heard about the 33% reduction over the last 30 years in cancer deaths. Some of it is from all the great cancer treatments, but a lot of it is from cancer prevention. So you got to get it from both sides to make it work. And then again, I started talking about the insurance industry. At the industry level, for some reason, in the last 20 years, the community oncologists have sort of been pitted against the academic oncologists, competing for price, competing for patients. That's not a patient-centered point of view. And I don't care how nice you are to your patients in either setting, if you're not allowing them to move fluidly back based on their need and their desire, it's not real patient centricity. So we need to get out of this bid one against the other to get the lower price, to say, how do we on one hand encourage the community oncologists to identify those patients who would be qualified for a trial, minority and white, to get to a trial? How do we identify the people that have a complex need and get them to the academic center? And on the flip side, how do we get the academic centers to be accountable to disseminate that information more quickly into the community so patients can get the right care closer to home in a more comfortable setting surrounded by their family? We don't have that sort of collaboration. I hope we have some time to talk about some solutions where we're beginning to see that. But if you really want to create an ecosystem that's supportive of patients, of of both minorities and non-minorities, you need to fix the infrastructure. And right now we're just too broken. And we're actually, as I said earlier, we're adding to this disparity.
Yeah. Really quick. Just want to let everybody know I'm going to be asking a round of questions in about 10 minutes. If anybody has any questions, they can jump up, but just start thinking of your questions. So that's a preemptive warning. But go ahead.
Back to the broken system to some extent. We are unfortunately in this country a sick model instead of a wellness model. And in fact, that's changing the whole dynamic as well, the whole culture, because money is not put into prevention. And that's where we can start to stop this problem. I know that there are wonderful and fabulous innovative changes in cancer care. Chemotherapy was horrific. I hated it. And now you have immunotherapy, and you have cell gene, and you have CRISPR, and of course Dr. Harlan has Dr. Levine has a bunch of those. He could name all of the fabulous kinds of innovations. But I said I would rather get someone at stage 2A and give them, a life-saving kind of care and send them on their way than a fourth stage that might give them 6 more months of care, but they die anyway because they're late stage.
And by the way, from an affordability point of view, it's 2 to 4 times less expensive to get someone in early stage cancer than to treat them in late stage cancer. So, it makes sense. You just have to be willing to make that investment up front to find those patients.
Well, look at this. Now, Eric, this is, because they need to know this. They possibly don't even know it, but you all know your health care is more expensive than it should be. This is cancer care. In 2021, over 80% of patients said they'd made financial sacrifice to afford care. People making less than $70,000 said cost governed the decision about care. People making less than $35K are more apt to delay or not to skip filling prescriptions, or they cut pills in half to reduce, so it lasts longer. 44% dipped into their savings, 36% went into credit card debt, and nearly a quarter said they did not schedule or cancel, or they canceled an appointment because of the cost of the procedure. So bottom line, they're kind of, if you go to a doc and said, I didn't take all my pills, doc, because, and the doctor will say, well, you're out of compliance. The system is out of compliance when people can't afford their own health care, or it drives them into bankruptcy, or they're constantly in medical pain from the affordability. Financial toxicity is a huge problem.
Yeah, I want to talk about that a little bit in terms of reform. Circling back to something you said a few minutes ago about national reform. Talk about rolling out what you've done in California, doing it on a broader scale, and does it tackle these financial problems that people are dealing with?
Yeah, so we're doing a few things nationally. I do want to, well, I'll answer your question. I do want to make a point about why this all matters. It really matters if you have access or not. But we'll get to that in just a moment. So we're doing a few things nationally that I think are important. So I mentioned earlier that we're now in 3 additional states. So we want to go through the same process we went through in California, which is to state by state, get a cancer center bill of rights, and then also make sure we mandate access to the academic centers. And these are, again, for the most complex cases where you really need that access. And then, given that we now have this national footprint, we believe there ought to be a national Bill of Rights for cancer patients. And I think just making people aware of these issues, even if you don't achieve everything you want through a lack of legislation, you educate communities and policymakers and health plans and you, the voice, the people that vote, on the fact that we really need help for, I'm going to say it's not just for the underrepresented, by the way. I'll make that point in just a second. But we need help for the underrepresented. The system does not work for them. And if we really want to have a society of justice and a healthcare system that's equitable, we're going to have to do something that's disruptive. Like doing what we do now is going to make it worse for cancer patients. And that's not, for those of you who are in healthcare, I am not saying that we have not made great strides in terms of other areas of preventive care, vaccines, things like that. But when it comes to cancer care, we're moving in the wrong direction. So I think a national Bill of Rights, national cancer patient Bill of Rights is important. Let me tell you that I don't want people to walk away to think that this is either one community at a time and it's going to be a struggle. It will be at the community level, but there are national things you can do that are already taking place. About 5 or 6 years ago, we recognized at City of Hope that we, like many other cancer centers, were a center of excellence where patients could come to us if you had the right insurance, for the most complex care. I do want to clarify, City of Hope takes charity care, all forms of insurance, but the groups themselves sometimes have barriers and make it hard for them to come to a center of excellence. So we thought about the idea, well, what if we took our expertise and did the reverse and disseminated it out into the community? Well, how would we do that? So we thought the best place to start was with the employer market, because in the employer market, we see the same disparities. Your death rate from cancer depends on your insurance product, your zip code, and your race, just like it does in the underrepresented, in the poorer communities. So we found many employers were interested in engaging a City of Hope to have their experts do second opinions to help support the care of the patient in the community. In other words, you get a complicated cancer, we proactively reach out to the doctor and say, we're here to help. And we help them manage the patient. So whether you work in the boardroom of a company or in the mailroom, you get the exact same level of expertise. Well, that has actually taken off. We now cover more than 7 million members. 400 employers have signed up for this. The point is there are things that could be done that don't have to disrupt the whole system overnight. You could really just assist or enhance the current system that exists. And I think the purpose of that, I see heads nodding, so I see people like it. But what I really like about it is it gets academic doctors talking to community doctors, exchanging information. So all the great science is happening in an academic center is quickly getting out there. And City of Hope's not alone, by the way. We brought in partners, Dana-Farber, Northwestern, Emory, Johns Hopkins, the Fred Hutchinson Cancer Center up in Seattle. They've all joined, and they all have their experts helping general oncologists throughout the country, working for employers and a few health plans.
Can I give you an example, though, where we're trying to work on the policy side of things? Because we discovered when we were introducing Spanish-speaking women to the whole concept of of risk as a result of a family cancer history, and we educated them. We used a survey tool. We found out of 1,020 women that we talked to, we found about 120 of them who actually had some kind of history that we should be getting them genetically tested. And then we turned around to the federally qualified clinic system that we were working for, and they had protocol, payer, and policy issues that it took us 16 months to get the first woman to sit down with the doctor to determine whether or not she would get the test. Mm-hmm. 16 months. This is in California. And so what we started to do was we started to put this to the test through formalized research with my colleagues at UC Davis so that we could show that there was a problem. Stanford has already put out a paper that shows that lower SES women are not regularly referred to genetic or genomic testing compared to other women. And once again, has a lot to do with, where you live, your insurance product or not, and even bias.
That's actually one of the big takeaways is I want people to know, first of all, for Medicaid, they didn't even cover genetic testing until recently. And I think there's some recent laws that may be changing that. Just because you have insurance coverage does not mean you have access. And while I don't want to make this too political, I support the Affordable Care Act and very strongly supportive. We can't stop there. Having insurance does not mean you have the appropriate access, and we don't want to water down insurance so much that when you most critically need it and you're the most vulnerable, that you can't get the care that you need. I keep threatening to tell you why I think it matters. Let me tell you why it matters. 10 years ago, if you had metastatic lung cancer, how many months do you think you lived on average? Just throw out a number.
2.
Okay, so on average it was 6 if you had metastatic lung cancer. Today, for many of the subtypes of metastatic lung cancer, with the new treatments, the expected life is 70 to 80 months, and things are changing. So 10 years ago, if you were not on a clinical trial, you are dead. If you're on a clinical trial, you have a chance of still being alive today, although you certainly got 5, 6, 7 years out of being on the clinical trial. So, dramatic difference. Now, it took years after FDA approval to get that information to permeate into the community. So even after FDA approval, people were not getting the care. As recently as 4 or 5 years ago, 72% of lung cancer patients were still not getting the genetic test that told them which targeted therapy. Now, I'm not a big person on quizzes, but I'll throw out. Here we are in 2024. The medicines have been out for 10 years. It's been part of the established guidelines called National Cancer Center Network Guidelines. What percentage of patients do not get the genomic testing today? 48. And of the 40, and then in addition to that, 15 more percent don't get the appropriate therapy afterwards. So here we are, 10 years afterwards, and over 50% of people are not getting the appropriate treatment for metastatic lung cancer. Life-extending, significantly life-extending cancer treatment. So it's just an example that, on one hand, if you don't have the right access to a research trial, you may not be getting the best treatment, but also the failure of the system, including academia, to get that information disseminated into the network. So we have to build an ecosystem where it's collaborative, they're not pitted against each other, and we figure out how to get fair payment to everybody so people aren't fighting over cancer patients. We should be fighting for cancer patients.
And all clinicians are informed.
And all clinicians
because that's part of the big problem too, is
know what they need to know.
knowledge. Yeah.
So last question to the both of you, and then I'll see if you guys have any questions. So what is next in your work on this front? Who wants to go first?
Oh, I'm learning to make the sausage. I mean, bottom line, I'm starting to see more and more where it's systems problems. And to me, if we solve the problem at the systems level for those who are the most underserved, we're solving the problem for a lot of people, because it means the system will change. But we know that there are the systems that serve the underserved are under-resourced. So it's always about the money. Bottom line. And too often I say, too often people look to monetize or where they do the savings, and it's always on the back of poor people. So there's a lot of things that have to be done. Some of them are ethical and moral, and others are just plain old, it's just like we keep talking about inflation today and the fact that there's a lot of price gouging going on. I know how long it takes to do research. I mean, for a pharma drug to come, how much money they put into it, but I just think that they're overpriced when it comes to putting the drug into the market. And so we all have to have a change of attitude, and we all have to work together, but I think that, not in my lifetime.
Harlan?
Yeah, so just to pick up on Ysabel's point, there is an affordability issue, but there are enough people out there making money off of healthcare that we can afford to provide better cancer care to everyone equitably across the country. My areas of focus, there can't be a single next step. There has to be multiple fronts that you're trying to fight this war on behalf of cancer patients. To pick up on some of the things we talked about today, one of the areas that I'm really interested in is looking at Medicare Advantage. If people aren't aware of Medicare Advantage, but since the 60s, I believe, we've had Medicare program for seniors. Over the last 20 years, they've been moving into a managed care setting, and it's now 55% of seniors have Medicare Advantage. If you look at the data, again, you look at complex liver and gastric surgery and Medicare Advantage, 50% higher 30-day mortality rate than traditional Medicare. For pancreatic surgery, it's 100% higher mortality rate than traditional Medicare. I am a big fan of Medicare Advantage. It works for so many areas. The problem is that when you have a narrow network of the Medicare Advantage plan, you end up at a low volume hospital for highly complex surgery. So my next area, we've talked about underrepresented, we've talked about poor. I'm also focused on seniors. I want to modernize our definition of what we call network adequacy, which is a term of art, to understand that cancer care is different, it's advancing quickly. There's incredible breakthroughs and innovation that can help so many, but we're creating a system that actually restricts access, and I want to reverse that. I don't want to break apart managed care. I don't want to brush aside value-based care, but I want to define value the way a patient would define value, which is going to be survival, normalcy, return to functionality, whether I was treated respectfully and culturally sensitively, and whether my care was coordinated. So let's redefine value-based care, and then let's take our major insurance programs, Medicaid and Medicare Advantage, and let's get them right. That's my area of focus for the next year or two.
And I think, can I just say, honestly, that this requires your engagement. I think we started off with that. This means
I love it, a call to action.
Well, it is part of, first of all, what City of Hope is doing with us, but I think it's also really critical because I, in doing this, am looking and working with a lot of Latino lawmakers. And I asked Joaquin Castro, congressman who himself is facing a very challenging neuroendocrine cancer battle, and then recognized how much it cost him, like $12,000 a treatment, which is every month I think he has to get. And when he suddenly realized that, he says, I'm all for universal health care now. That was where his head was at. But I said to him, how really critical, I mean, how much does it matter when a patient advocate or a community member comes to you and raises an issue? And he says, in all of my career, he says, they've had the most power. They've made the biggest difference in what we pass. So I just encourage you to not think you have no power and that your voice is not heard. They actually do listen to you in whichever state you're in. It is kind of up to you to help make change at whatever you're interested in. But if you care about the cancer issue, which is going to impact 1 out of 2 Americans, is it not, in our future? It's 1 out of 2 Latino males and 1 out of 3
Directly
Latino
or
females.
indirectly.
So it's huge, no matter what. Even if it's a chronic disease, it's going to happen to a lot of us in our lifetime.
How many of you are convinced that those of you who were scanned in the way in are going to get a call from Ysabel when this is over?
You can give me your number as I go.
There's a quiz for you. So we have a few minutes left. I want to see if anybody has any questions. I can line up at the mic.
Hi, so I have a question. You've talked about how in California, for example, about half of patients don't get treatment that's concordant with national guidelines. Presumably that's happening in other states. I'm just wondering if you could tease that out a little bit more and talk about where exactly the disconnect is happening. Is it a matter of providers not even knowing about the guidelines, or is it more like access, like maybe patients don't get referred where they need to, or they can't afford genetic testing and that sort of thing?
Do you want me to start?
Yeah, you go, because you know the hard stuff.
Well, you were talking about deletions and additions to alleles. I was pretty impressed. I had troubles a little bit with the acoustics, so if I get the question wrong, please come back and just ask the question. I think part of the problem is in terms of like why isn't every state addressing this, and how do you go about it? And like, the problem, I think, is a lot of people just go about their job every day and no one's trying to do harm, right? So the doctors seeing patients in their practice aren't consciously thinking, I'm not going to send a patient off for research. They're just trying to take the best care they can of the patients with under-resourced. I think at a legislative level, there is a lack of understanding of how severe the gap is. And quite frankly, narrow networks, when they started to come into fashion 15 years ago, 20 years ago, they were fine because the cancer treatments weren't that good. The research trials weren't that good. The chemotherapy wasn't fun. It also, for many, wasn't all that successful. So we're in a world now that is just a paradigm shift from where we were 5 years ago, and the technology is exceeding our social infrastructure to keep up. So I think it's a lot of the advocacy and the collaboration that Ysabel is talking about, and is, to be perfectly honest, more expert. You know, we have teams at City of Hope that join Ysabel and are really amazing at doing this, but we've got to pull organizations together like Ysabel's and many others to make people more aware that the science is way out in front, but only for a few. And we have to just educate, and then the legislative change will come.
And one of the things he just said, educate. I think we're really falling behind in even teaching our youth about health and giving health education. I don't know how many schools have taken it out of curriculum, where they've taken health education out. So we need to teach young kids health literacy. We need to teach teenagers health literacy. We need to teach the science, the communication of science to them, so they're not fearful of the science, but in fact embrace and try to understand it. But the best person to help make the change is the patient and the patient advocate. AI can play a really important part of that, or it could become our Waterloo. It can become very different.
We're in the Waterloo. There's nothing wrong with that anymore. So.
It could become problematic.
We have a person.
I wanted to just say, the Light Collective, which is a group of very impassioned patient advocates, are building the AI Patient Bill of Rights, which we will be putting out in a couple of I'd say within a month.
I just want to comment. I know we have someone waiting. How complicated this is. I was with the CEO of the American Cancer Society Cancer Action Network. I have to say that because she's not allowed to advocate as ACS, but she can as part of the Cancer Action Network.
Yeah.
And we were talking yesterday on a panel, and she was pointing out that flavored menthol is out there and is targeted for the African American community. But because of the politics and the money involved, a lot of politicians are afraid to go after it. And we just are going to have to make federal, I mean, I'm getting political again, but I mean, come on, guys. I mean, you're making addicts out of underprivileged kids at a young age by flavoring and then hiding tobacco. We just got to stop doing things like that.
Absolutely.
Last question.
Sure.
Second to last question.
Thank you. I really like the concept of the Bill of Rights and expanding that into a national potential forum. But one thing I want to talk about is states that don't maybe have a very different mindset, such as, red states and states that turn down Medicaid expansion, states like Florida, Texas, we're in one of those states. And actually, how do you change the argument to get allies in those spaces, in those legislative political environments? I know people shy away from politics, but it is political. That's being frank. And so recently I was listening to something on NPR about how to convince someone that maybe has different views than you, that you have to actually maybe find a vantage point that comes from their belief system and maybe have them see an advantage from their point of view. I don't know if in your experiences you have had to convince someone that may not have the same values and alignment as yourself, and what are some strategies to do that?
Well, I think we have to commit to short answers. So
We got like 5 minutes. Right?
okay, so do you want to go first?
No, I never have short answers. You go.
So, very difficult challenge, and I think there are certain things. So I think this is about education and messaging, and there are certain things that are just universal. And I think that something like cancer does bring things across, does bind people together. I will tell you, as blue as California is, as many of you know from national politics, we have some pretty strong Republican sections of California. This thing passed unanimously. It passed unanimously. It was told in a way that was easy to understand. It made its point compelling that it was not just for one segment, it was for the entire population. And I think if you can try to depoliticize the topic and bring it back to cancer. It is one of the most emotional parts of healthcare. So I think that's number one. Number two, what I would say is messaging is really important. So take, for example, Ysabel mentioned vaccination. HPV vaccination, if done correctly, can eradicate cervical cancer. If we make it about vaccination or we make it about STDs, it's going to be very hard to get people to take it. You have to make it about cancer. So again, it's
Saving
just
lives.
Being thoughtful about how you message. We should learn so much from COVID about how things can go completely awry when you get the messaging wrong from the very beginning. And if it's not apparent, I kind of lean a little bit on the blue side, or maybe more than a little. The blue side did not do very well on communicating this, and I have some very close friends who are actively involved in that, so I got to be careful about my personal relationships. But we got off on the wrong foot, and we didn't help either side. So messaging education is really important.
All right, last question, and we got to make it quick.
Okay.
Thank you.
My question is, how are we addressing...
Step closer to the microphone.
Sorry, how are we addressing ageism in cancer? For example, I'm 36 years old. I have stage 4 metastatic breast cancer. As far as the first cancer center that I attended to, it was all white women, older white women.
Mm-hmm.
Although black and brown women tend to die at a faster rate because of delayed diagnosis. So that's something that I'm always kind of interested in seeing what we're doing to address that. Because even the Cancer Society still says, the American Cancer Society says 40 to 49 years old.
Right.
I was 32.
Yeah, exactly. Which is one of the reasons why I refused to even follow the guidelines that we would move up to 50 for mammograms, because I said, I'm seeing young women, Latinas, coming in at 28 years old with breast cancer. Don't tell me that we should switch this on them. But there are a number of young women coalitions that you should look for. That's your first line of attack, because they are doing the patient engagement that you're talking about, and they are fighting for that space. And they know, and they're angry because they're not being recognized, because they go into the doctor and the doctor says, oh, you don't need it, you're okay, don't worry about it, et cetera, et cetera. So yes, there is ageism, and everybody thinks this is an old person's disease. One of the fastest climbing cancer rates in the Latino community is pediatric cancer, young people. So it's everybody's disease for multiple reasons, including the social determinants of health and environments that are now toxic in many of our neighborhoods, et cetera, et cetera. So, but you can find advocates, and that's what you should look for first. The people who speak your language, understand your pain, and can embrace you and make you feel that you've got something to fight for and that you should fight for.
And then Harlan wants to have the last word. He promised me to be quick.
Great. I just want to thank you for your courage in coming to the microphone. I'm sorry for what you're going through. Cancer is occurring in younger people. We're going to have to learn. I do want to connect it up to so many of our guidelines are not appropriate anymore for people who are at high risk or different groups. And it's not just fancy research with genomics and therapeutics. It's research and understanding the appropriate way to screen people that needs to get done as well. And the system has most likely just failed you in that regard. But do find people like you who have gone through the experience, so you're not alone. They're out there and sadly growing in number.
Yeah.
Yes. Well, thank you both for taking the time to do this, and thank you all for coming.
Thank you. Good group.